Hello and good morning, everyone, for the today's session. I'm Dr. Vinaya Kundapur, moderator for today's CDE session on behalf of FSCD and also in collaboration with KSR, we are going to have this wonderful CDE today with our eminent speakers. I work as a clinical assistant professor at UT Health School of Dentistry at Texas, USA. Today, it's my honor as a part of Federation of Special Care Dentistry and also as a part of CD convener along with Dr. Smita Tavale ma'am. I would extend a warm welcome to you all and would like to begin this session for today. A brief about FSCD. FSCD is a special care dentistry organization. This is a society that is specially dedicated to the people with special needs. Age is not really a factor here. We treat all the patients for all ages and we have different umbrellas with this organization. So mainly our goal is to deliver oral health care needs to the aging adults as well as the adults and children with special needs. And also we mostly focus on providing and sensitizing education in order to improvise the oral health in this special needs population. So main goal is we align and collaborate with many of the institutions, and one of our very fond and always been in touch is with the KSR Institute. It's very dear to us for multiple reasons. One is we have a very proactive board member, Dr. Esther Nalini, and we have a very supportive pedodontist, head of the department, and also the principal of the institution, Dr. Sharad Ashokan. His achievement speaks volume about him. He has been a young pedodontist award for over the years, and he has been recognized and awarded with multiple things even in the past. His publications are very popular worldwide, and also I'm sure in India, his books have been referred by many. So the main passion he has towards this pediatric dentistry and also to educate the younger adults has also been a good collaboration and foundation for us to have multiple CDs with this institution. They also have a very dynamic chairman who has been very supportive, who normally encourages all the brilliant minds, and they have a very special clinic that is mostly encourages for the comprehensive and advanced dental care. With all this background and motive behind, it's always been a pleasure for FSCD to collaborate with KSR to host multiple CDs, and we always appreciate their support in this. We have our eminent speakers for today, and the main foundation Secretary General is Dr. Priya Verma, who is the founder for FSCD. She has been a greatest support for us. We have multiple specialty boards under this FSCD, and Board of Geriatric Dentistry is one of it. We, the board members, have been very supportive, but we are led by a very dynamic chairperson, Dr. Manu Ratti. And that's all the reason that we feel more motivated and encouraged. Today, we have a very eminent speakers from the United States who have well trained from India with a very good background of Indian approach, which they understand and they have delivered the care. And they traveled overseas, got themselves updated, got a new approach, and they have been practicing since years in this country. So with both the foundation they have, I'm sure it's going to be a very good approach for all of us to have this most awaited session. I see that our principal and head of the Department of Pedodontics, Dr. Sharad Ashokan, is joined online with us. Sir, we would like to welcome you for the today's session, and we really appreciate your kind support. We would really request you to speak a few words before we begin today's session.
Thank you so much, Dr. Vinaya. This has been a wonderful association with the FSCD, but I think all the thanks goes to Dr. Esther, because the college and the management has only been supportive here. But I think she's been doing a wonderful job being a part of the board of the geriatric board of FSCD. I got into this association because of Priya Verma and Srinivas sir initially, and we wanted to get into the autism board. That's what my plan was as a pediatric dentist. But I think all the credit goes to Dr. Esther for taking this initiative. I think she's continuously focused on having CD programs and workshops and conferences. Thank you so much again for giving us an opportunity to be a part of this wonderful program. And all the best to all the delegates. I'm sure you're going to have a wonderful session. Thanks to all the resource faculty who are ready to share their information and experience on this particular topic, which is really important at this point of time. Thank you so much.
Yes, sir. Thank you so much. Yes, we indeed are very much indebted to Dr. Esther. She's been a very proactive member. As I told, the leadership, the visionary leadership holds a very important thing here. You have been very supportive. And same way, we have a very dynamic leader who is leading our board. So with everyone's support, we have been able to move forward with this. So moving forward with today's session, we have a chairperson for today, Dr. Sridevi Kaul. I would like to invite her for today's session and introduce herself, and so that we can begin the session without taking much of everyone's time. I'm sure everyone are awaiting for the most, the interactive session for today with the clinical approach to geriatric population.
Good morning,
Dr.
everyone.
Sridevi Kaul, over to you.
Thank you, Dr. Vinaya. Thank you very much for the introduction. Good morning, everyone. Thank you for being here. I'm Dr. Sridevi Kaul. I'm a prosthodontist from India by training. I worked in a few colleges in India before moving to the States in 2015. I got my DDS degree and I now practice and live in Boston area. My clinic is in New Hampshire, but I live in Massachusetts. Without taking much of your more of your time, I will just straightly go to the introduction of speakers. We have three eminent speakers: Dr. Yuvika Rajkumar, Dr. Vrinda Gupta, and Dr. Ankur Kaul. They will be touching on different aspects of edentulous patients and how to starting from extractions till the denture care. So over to Dr. Yuvika Rajkumar, the first presentation. Dr.
Good
Yuvika.
morning, everyone. Thank you for being here on a Saturday morning, and thank you for giving us this opportunity to share our clinical experiences. Again, without taking much time, I'm going to just start my presentation. I'm going to share the slide. Is there something with the screen sharing?
Are you able to share it?
No. It says host disabled participants
okay.
screen sharing.
So maybe Dr. Esther, I can use.
I think we have to make her the co-host, a host.
Yeah, the host setting needs to be changed.
Yeah.
A minute.
Okay.
Yeah. I think they will make you co-host and then you'll be able to share your presentation.
Okay. Do I need to do anything or?
No.
Okay.
They're already changing it.
Thank you.
I thank you all for staying awake at night. Good,
Thanks.
Yuvika.
It's midnight here.
Oh, that's what I'm saying. So you're already in Saturday, early Saturday, is it?
Yeah. Yes. It's still not allowing me to share.
Dr. Esther, give us a heads up once she's a co-host.
Okay, I think I got a message.
Yes, we can see your presentation.
All right.
Yes.
All right. So I'm Dr. Yuvika Rajkumar. I have been trained as an oral surgeon in India, and I came here in 2015 for my DDS. Before that, I have worked in Maulana Azad Institute of Dental Sciences for 5 years. And here I work in a private practice in the state of Connecticut in the United States. So I apologize, my presentation is very dry. It has just like snapshots of articles, but it's more evidence-based, and it's covering like the most recent updates and the needs and the things that we need to take care of while we are going for the procedure of extraction. So these are the topics that I'm going to cover today. It's going to be a short 10 to 15 minute presentation. I'm going to go straight into the causes of tooth loss. So there are many causes of tooth loss, and the main ones are listed here. It could be caries, it could be periodontal disease. There is a higher risk of root caries in older adults. There could be medication-induced xerostomia. There could be infection, tooth fractures, a cracked tooth syndrome, or poor oral hygiene could also lead to tooth extraction. So once a diagnosis is established that the tooth needs to come out and is non-restorable, now we need to make sure that the procedure is comfortable for the patient and is executed in a very safe environment. So in order to do that, we first need to start with the medical history of the patient. I'm sure you all take care of all the factors listed here, but I'm just going to quickly touch base with every one of them. The first is blood pressure. We all know that it's very important to take blood pressure before the procedure and follow the ASA guidelines as far as treatment is concerned. Coming on to diabetes, it's a very good idea to have a HbA1c number because we know that diabetes is directly related to healing. If this is not available, then a very recent blood sugar level will also work. Next is blood thinners. These days, we see that there are a lot of patients who are on blood thinners. Routinely, like there is no need to stop the blood thinners if it's just 1 or 2 extractions, but it's a good idea to talk to the patient, to the patient's doctor in case any alteration is needed. Moving forward, joint replacements. These days, we see a lot of patients have their joints replaced, and the main concern would be antibiotic prophylaxis. The recent guidelines say that there is no need for antibiotic prophylaxis if the procedure is done like over 1 year. But again, every patient's immunity is different, and it's again a good idea to talk to the patient's physician. As far as cardiac conditions are concerned, only a few conditions like valve replacement or a prosthetic valve, in those situations, we would recommend antibiotic prophylaxis, and I would go over them in the coming slides. Next is cancer and radiation. Cancer by itself has no contraindication to extractions, but radiation has, especially when the radiation is in the area of the extraction. So again, we need to talk to the radiologist, like what kind of radiation was used, the amount of radiation, and we need to modify the procedure accordingly. Bisphosphonates are also the drugs that alter the bone metabolism, and we need to be careful about the dose that the patient is taking, the frequency and everything. There is no absolute contraindication. For example, if the patient is taking IV bisphosphonates twice a year, then we can space out the extraction away from that time. But again, we should consult the patient's physician in order to make sure that they have a safe post-operative healing period. And medications are also important because they interact with each other. So we need to know what the patient is already taking so that we can prescribe our medication based on that. So having a medical clearance in case of a complicated medical history is making sure that we keep the patient safe. So there, I'm just showing you a sample of a medical clearance form. You could have your own. Basically, we want to know from the doctor whether the patient needs antibiotic prophylaxis. Do we need to stop the blood thinners or not? Or do we need to alter anything else to make the procedure safe for the patient? Coming on to antibiotics. Antibiotics by itself, it's a detailed topic, but I'm just going to touch base with the recent guidelines. So antibiotics should be treated as a resource that is naturally limited. clinicians must consider that the potential effect of their antibiotic prescribing choices on the larger community as well as on the individual patients are very, very important because there are risks to both. There is something called as antibiotic stewardship. It's basically a program that works to ensure that patients receive antibiotic therapy only when it is indicated and that the right drug is prescribed at the right dose for the right duration. Now, these recent articles are coming up, which are talking about use and misuse in dentistry in India. So basically, the reasons for this misuse is prophylactic antibiotics, therapeutic antibiotics, or sometimes the patients self-medicate themselves. So that leads to a lot of like antibiotic resistance, but there are no like targeted programs in this area that can help us have some guidelines to prescribe them. This is another article which again says that there is an urgent need to have some relevant guidelines in this area. Now, this overprescription and self-medication, it causes a problem for medical issues as well. This is a 2022 study by ICMR, and they say that certain drugs are no longer helping the patients, especially in ICU settings. So we need to be very, very careful when we prescribe antibiotics. So as a provider, as a clinician, these are the questions I would think about. Like, does the patient really need it or not? And how will I decide that? Is the infection localized or generalized? What is the medical history of the patient? Can I create an aseptic environment? How is the overall immunity of the patient? Is my procedure invasive or not? And then I need to understand the nature of the infection, whether it's bacterial, viral, or fungal. And based on that, I will choose the antibiotic that will be most appropriate for that situation. Then I will think about how can I limit that use of antibiotic. So it can be procedural, for example, drainage, root canal extraction. All these things can help get rid of the infection and can reduce the need for the antibiotics. And then I would finally look into what are the latest guidelines for the antibiotic usage. But in the end, it is a clinical decision. If we have a patient in chair and there are no indications for giving antibiotics, but if the doctor feels that this patient needs antibiotics because of immunity or how the patient is looking, then please go ahead and prescribe that. But we do need to think from a broader perspective that whether there is a need or not. The next few slides actually go over, they will help you decide whether, to give antibiotics or not, but I'm not going to go into the details of that. So something like chairside prescribing, like we should not get, sometimes patient will ask like, oh, can you give me antibiotics? I'm having pain. Can you give me antibiotics? So it's our duty to educate them whether antibiotics are even needed in that situation or not. So this is like just educating the patient to take them as prescribed, not just take half doses, and also not save them for future illnesses or share them with others. Coming on to antibiotic prophylaxis. So there has been few changes in the past, and really there are only a few situations where the antibiotic prophylaxis is needed, and that's more like for cardiac situations. So these are the only situations where the prophylaxis would be needed, and this is pretty latest. But again, if the clinician feels that it is more safe for the patient to take the antibiotic prophylaxis, then we should still go ahead and do it. This is the latest regimen, and if you see clindamycin is no longer recommended. It has kind of a black box warning because of the colitis that it causes. And especially in older adults, we really need to be careful. Actually, azithromycin is a good alternative if somebody is allergic to amoxicillin. And I'm happy to share all this in the end or through email. Now, coming on to the procedure, when the actual procedure, when the patient is in the chair for the actual procedure, we need to understand that older adults have delayed healing. And this could be because of many factors, such as surgical trauma, medical and medication history, smoking, alcohol use, and a limited understanding of the post-operative instructions. Out of all these factors, surgical trauma and limited understanding of post-operative instructions can be controlled. So, which makes me talk about atraumatic extractions. This word, atraumatic extractions, got popularity when implants came in. Like, we felt the need to preserve bone because we had to place an implant, but that should be our default mode, to do atraumatic extraction for every patient, whether or not the implant is being placed or not. So in order to do that, there have been like multiple armamentariums, systems that will help us achieve to execute an atraumatic extraction. I'm not going to go over it because everybody has their favorite instrument and way to do it. But the main foundation is that we need to respect tissues and that tooth belongs to the surgeon and the bone to the patient. So in my hands, I have used these luxators and these skinny diamond burrs, and almost 95% of patients do not have pain when they come back for their follow-up. It has really reduced the amount of analgesic I have to give to the patient, and they're very, very comfortable in the post-operative period. As far as post-operative instructions are concerned, when the patient is in the chair for an extraction procedure, they are anxious and they would not even listen to half of the things we are telling them. So normally I would numb them and then go over the post-operative instructions, then perform the procedure and go over the instructions again, and then give them like a write-up of the instructions. I would also put in the medications here so that they have something to refer to when they go back home. One last thing I would like to mention is that it's something very simple, very basic. Everybody uses it. The use of ice pack. I have noticed like if an ice pack can be provided to a patient as soon as the extraction is over, it really changes the post-op pain. It reduces it. There is less swelling, less pain. So that has been a game changer for me. But yeah, coming on to the end, preparation is the key to successful outcomes. Going over the medical history, collaboration with the patient's medical doctor, awareness about the latest guidelines, and having the armamentarium to manage the possible complications and post-operative care will help execute a smooth and comfortable surgical procedure for the patient. I thank everyone, and please feel free to reach out to me if you have any questions. Thank you so much for your time.
Thank you, Dr. Yuvika, for your wonderful presentation. With the growing demographics of older adult, it's very important to sensitize few things which are very important, especially when it comes to the responsible use of antibiotics. Preserving hard and soft tissues become paramount important when they have many other medical conditions. So this presentation has been insightful to all. I would, without wasting much time, I would hand over it to the next speaker. Once we are done with all the presentations, then we will look for the valuable inputs from our chairperson. Maybe you can have Dr. Vrinda have the host and have her screen sharing. And I also request Dr. Vrinda Gupta to introduce herself and start with the presentation. We have many participants here today, and I received greetings from Yanapoya Dental College. Thank you so much for joining. Thank you all for your wonderful support. This is not going to be meaningful without having an active participant. Please feel free to shoot your questions on the chat box, or you have time in the end that you can make a note of it.
Good morning, everyone. Thank you for coming here on a Saturday early morning. Am I able to share the screen?
Yes, I believe. Let me just. I believe they've made you the host now, so you should have an access. Do you want to try?
A message that she's the co-host.
Is the screen visible?
Yeah, it's just coming up.
Yes,
it's
yes. I
visible.
think you need to go to the presentation mode, but as of now, we can see the screen. Yes.
Yes.
All right, that's great. All right. So, hello everyone. I'm Dr. Vrinda. I have recently completed PROS residency in US from University of Texas. So a little about my background. I did BDS from Manipal University, did my internship from PGI Rohtak, my hometown, and then I did MDS in PROS from RGUHS Bangalore. So for today's presentation, I would be talking a little about planning and concepts in complete arch implant rehabilitation. Without going much into details, since we have limited time, I'm going to focus on a few points that are really important to be considered before we actually begin the treatment. And that includes patient's aesthetic analysis, hygiene, and restorative analysis. And then I'm going to discuss the differences in the workflows in conventional and digital approaches. So we start our diagnostic phase with medical history and dental history evaluation, and Dr. Yuvika has already
Sorry to
spoken about it.
interrupt. Maybe you need to put it on a presentation mode. I'm sorry.
Is it not on the presentation mode?
I don't see it that way.
No, it's not on the presentation mode, Dr. Vrinda.
Yes, you need to put on a presentation mode probably. Yes.
Okay.
In the US, we mostly use Teams, so Zoom is like a very limitedly used platform. So
Okay.
although it all looks like almost the same, but sometimes we have this technical difficulties with virtual presentation. Apologize for all the inconvenience.
No problem. I'll just say that even if it doesn't go on the presentation mode, you can scroll the slides and we can.
No, it worked when she practiced. So let's just try one. Yeah, let's see.
Okay, let me
Because
see again.
it's a very good presentation. So I want all the participants to get the best use of it.
Is it not possible to see the presentation at all, or can you?
It's not, it was not on the full screen actually. We can see the remaining sides on the left-hand side.
Is it visible now?
Yes.
Yes. It is visible.
Yes. Now this is.
Yeah.
Okay. So I would just move forward to the presentation. So we were here.
Yes. Now it's perfect. Thank you.
All right. Okay. So as we start our diagnostic phase, we start with the medical history and dental history evaluation, which Dr. Yuvika has already spoken about. So I'll just start with the aesthetic analysis phase, which starts with the facial analysis. Now I'm talking about it because right here in the US, photography and documentation is very important, because when we are planning a full arch implant prosthesis, as we move from the initial presentation of the patient to the interim phase during the surgical phase, and then the final restorative phase, which is about 4 months after healing, it provides us a way to go back and analyze things again if need be, as we would have a reference point. And then it is also important from a medical legal point of view. So for the facial analysis, we check the patient's facial midline, and that tells us about any gross facial asymmetry. And then we also check the parallelism between, then we also check the parallelism between the interpupillary line and the commissural line. So this kind of tells us gives us information about the occlusal plane analysis. And then we also check the we divide the patient's face into 3 proportions. And also this third proportion is usually reduced in older people, and that is due to reduced occlusal vertical dimension. We also evaluate the facial profile because it's important to assess the nasolabial angle and the lip support. For male patients, it's usually about 90 to 95 degrees, and for female patients, it is about 100 to 105 degrees. And that can give us an indication whether a fixed implant prosthesis can be planned or an overdenture would be ideal. So again, when we do our diagnostic planning, if the teeth are cantilevered more than 7 millimeters from the residual ridge due to resorption, an overdenture would be ideal to support the lip. Now here in these 2 photographs, we can compare. In the first photograph, the patient has a fixed prosthesis, And we can appreciate how much of a difference a denture flange has made in the second photograph. In smile analysis, we basically just look for any risk factors that can make the transitional line visible in the final prosthesis as the patient smiles. It can be extreme gingival display, or a hypermobile lip, or a short lip, or any indicators that would suggest a need for an excessive alveoloplasty. Like in the second picture, you can see the abutment portion on the lower lip, and that tells us that the patient's restorative space is compromised. A good way to determine this is to take a photograph of the patient in a high smile or an exaggerated smile. Coming to anatomical analysis, without delving into the basics of support, stability, and retention, we would plan the prosthesis accordingly. If we have good availability of the three factors, a complete denture will also give us a good prognosis. If retention is missing, we can plan locator over dentures. If retention and stability is lacking, we can plan an implant tissue supported over denture or a bar over denture. And if all three are compromised, we can plan a fixed implant prosthesis. But we also have to take care of the oral hygiene. We don't want to plan a fixed implant prosthesis for a patient who has poor oral hygiene. Because if the patient is not in the habit of maintaining hygiene, this is what can happen. And in this situation, we can either plan a removable prosthesis for the patient so that the patient can maintain the hygiene, or we can plan it in such a way that we keep the removable phase longer, and that will also give us time to assess the improvement in the oral hygiene before planning a fixed prosthesis. Diagnostic mounting, it allows us to check for any class 1, class 2, or class 3 ridge relationship. And this can give us a lot of other information as well. In this particular case, there were some signs of combination syndrome, and we would not want to plan an implant-supported prosthesis without doing posterior alveoloplasty. This is a very difficult diagnosis to make just from an intraoral examination, and the stakes become too high to go wrong when we are planning a full arch implant prosthesis because a huge amount of money is involved. Also, it allows us to evaluate the restorative space for each individual arch as we enter in the plan. The posterior restorative space in this particular case was not available for us to even plan a complete denture. Now, this is an article by Dr. Carpentieri, and it discusses the minimum vertical space requirements for each type of prosthesis. For FP1, when we talk about screw-retained prosthesis, it can be about 4 to 5 millimeters. And if it's an FP1 cement-retained prosthesis, it can be about 6 to 8 millimeters. For FP3, this is about 12 to 16 millimeters, depending on whether we are planning a zirconia prosthesis or a metal acrylic prosthesis. Now, coming on to the treatment planning, the conventional workflows include impression, analog guides, implant placement, and then conventional implant impressions, which are followed with the denture fabrication process in a nutshell. The digital workflows also, on the other hand, include 4 different aspects. These are 3D imaging and dental planning. There is guided surgery, and then digital scans, and computer-aided design and computer-aided manufacturing. So the digital workflow has its limitations in certain areas. It may be intraoral scanning of an edentulous arch. So what we like to do is follow a combined approach. Oftentimes, we would take a conventional impression when accuracy is important, or if it's an edentulous arch, and then we digitize it with a desktop scanner. Then go through the same CAD/CAM processes, and sometimes we like to finish the things with an analog method, which can be processing a denture to a bar that is milled or milled. So coming to the planning aspect, a completely digital workflow would involve using an intraoral scanner, and this produces STL file of the patient's dentition. And then we can also use the face scans to do our planning. We superimpose both of them with each other, and based on the aesthetic analysis and using anatomical reference marks, we can do a diagnostic backup or plan a digital denture. Now, there are different softwares that are available. This particular case was designed on ExoCAD and MeshMixer. Then we take a CBCT of the patient, and using teeth as reference points, the STL file of the patient's present condition and the future denture, both of them can be superimposed to the CBCT, and that's how we begin the implant plan. For an edentulous patient, a conventional impression-making approach may be more suited, and this is followed with jaw relations, aesthetic trying, and denture processing. So we place fiducial markers on the denture, and this is used as a radiographic guide. They can be placed either on the denture itself or a duplicate of the trial denture. Then we take the two CBCTs of the patient, one with the patient wearing the denture, and then there is another CBCT of just the denture with the markers. Then the patient's DICOM file, the denture DICOM file, and the denture STL file from our initial planning that we had done with the intraoral scanner, all of them are aligned together, and this is how we can begin the implant planning in an edentulous patient. So this becomes a combined workflow because we started with an analog way and then ended up with a digital way. There are studies which suggest that the precision of a CBCT is equal to a desktop scanner. However, with an intraoral scanner, there is more deviation and therefore lesser accuracy. The challenging areas can be the edentulous spaces, or whenever there is malalignment of teeth, it would be difficult to form the triangles. Some major advantages of adapting a digital workflow are that we can plan the augmentation procedures in a much better way. There is more information that's available to us. Our treatment plans can be more prosthetically guided, but the major advantages are that we can work on increasing the AP spread, and also in a high smile patient, we can we can do the alveoloplasty and position the implants accordingly, and also it allows us to assess adequate restorative space. Coming to template guided surgery, we have analog guides, and in digital, we have sequential or stackable guides. Now, an analog guide is an out-of-bound guide, and that is made as a duplicate of the denture in a clear splint resin. Then we create an occlusal window in the guide, which is then used for placing the implants, and also it allows us to time the multi-units. This out-of-bound guide can also be used as a bone reduction guide, because then we can maintain the adequate restorative space that is required for the final prosthesis. The lower edge of the denture flange, it serves as a reference for the reduction. So if you see in this picture, you can see the 3 points which are placed for the bone anchor pins, and we are using the lower flange for the reduction of the bone. For a sequential guide, after superimposition of the STL model to the CBCT, implant planning is done, and then the guides are fabricated. This can either be through milling or printing. So the first guide is a tooth-supported guide, and this was made in the Blue Sky Bio software. Now, using this, we position the 3 anchor pins, which are, if you can see the yellow, these are the guides for the anchor pin placement. And then using this, we would place the subsequent guides. Now, this slit was created as a reference for bone level reduction. Now, we also fabricate a bone reduction guide, and this goes into the 3 anchor pins. So this is a different guide, and that uses the same anchor pin slots. So we would just simply fix it back onto the anchor pin slots that we used for the tooth-supported guide. Next, we use the implant placement guide. For fabrication of this, the guide tube assembly from the implant planning software, which in this case was Blue Sky Bio. Now, this guide tube assembly is transferred to another software, and the guide tubes are connected. And we can also add a palatal support so that there is the fabricated guide is stable, and then we can print this guide. For this particular case, we also fabricated an interim prosthesis. It was digitally designed and milled for immediate loading. And now we can also provisionalize this using a palatal guide or a pickup prosthesis. Now, unlike the sequential guide, a stackable guide, there is a base guide that is always fixed on the anchor pin. So we don't remove that guide, but we add other guides to that first guide. The first guide is a tooth aligner guide and base guide, which is in the first photograph. The second guide is on the left. It is a bone reduction guide. The third guide is for implant placement, and the fourth guide is for the pickup prosthesis. For impressions, we have the conventional technique, or we can also use photogrammetry and intraoral scans. However, there are studies which are still ongoing about the accuracy of these. So in the conventional workflow, we would use a pattern raising jig, which is splintered in the mouth and the impression is made. Then the cast is poured with the implant analogs in the cast, and then we put scan bodies on the cast, and the scan bodies are scanned using a desktop scanner. So that puts our process back into the digital process. Now, in the digital impression technique, if we are to follow a completely digital workflow, we would use this technique. Now, titanium powder is sprayed on the soft tissues to facilitate the intraoral scanning. A first digital impression, which becomes an STL file, is made with the fixed interim prosthesis in place, and we also use anchor pins to serve as landmarks. Now, in the second impression, which is also digital, we would use the same anchor pins as a reference, and then we would scan the scan bodies onto multi-units. So the anchor pins, they remain as the reference, and then we would superimpose both the scans, and then that will allow us to fabricate the final prosthesis. This is another technique. Now, in this technique, because we have pellet, we have more references, and the fiducial markers can just be placed on the keratinized tissue of the palate. And then the same technique is followed where we are scanning the interim prosthesis with the fiducial markers. And then we are scanning the scan bodies with the fiducial markers. So the fiducial markers remain as the reference point. And then using that, we are superimposing both the scans, and then we begin our final plan. There are also other softwares which offer a closed workflow. This is Nexus, and it's a patented and a closed system. Here, the arch and the scan bodies or the scan flags, they are scanned using an intraoral scanner. The files are then uploaded onto the Nexus system, and then they will only plan and deliver the prosthesis to you. We also have photogrammetry. It's a very new technique where we are just taking photographs from different angles of the scan flags, and then they are aligned to the arch digitally. Now, of course, for this, we also need an intraoral scan, but the accuracy of this technique is within 4 microns, so it is pretty accurate, and it just takes a minute to make the impression. Now, comparing how much time it takes to make a conventional impression, whereas photogrammetry, it definitely has its use. Coming to the CAD/CAM prosthetics, now we can either design the bars digitally, and that saves us a lot of laboratory time. Now, for an metal acrylic prosthesis, right in the photograph on the left, we can see a bar being designed with superimposition of our denture. And in the lower photographs, you can see we are designing a completely FP1 supported prosthesis. And that's, we are going to use the intraoral scans that we had used initially. So in a zirconia prosthesis, the prosthesis is completely milled. Whereas in a metal acrylic prosthesis, we can mill the bar and acrylic separately and cement them together. Or we can mill the bar and process the acrylic in a conventional way, which again becomes, we are ending the process with a combined approach of digital and the conventional way. Talking a little about overdentures, the planning is done in a similar way. So there is denture planning, and then there is superimposition of the STL files on a CBCT. For locator overdentures, the locators should be as parallel to each other, and they should also be perpendicular to the occlusal plane to decrease any wear on the retentive elements in the abutments and increase the life of the prosthesis. Hence, for overdentures, locator overdentures, a fully guided surgical template is always advised, especially for the maxilla, as we are increasing the number of implants for maxilla, and again, the angulations of the implants also increase. Now we can also design an internal framework digitally, which can then be laser sintered, and then the denture is processed afterwards, and it can either be following the digital technique or following the conventional technique. Bars for overdentures, they can also be differently designed. So we have different designs for bars. There is Dolder bar, Hader bar, or a friction fit bar. In this particular case, this is an example of a Marius bar, which was designed with MK1 attachment. Now the bar and the substructure were milled, and then the denture was processed to the substructure. So this again becomes a combined approach. To conclude, there is really no optimum workflow for every situation, at least for now. A careful deliberation of what is needed, what is possible, and what is important should determine which workflow is ideal for that particular situation. The decision is mainly derived on the basis of accuracy, quality, time frame, and economic outcome. And that is all for the presentation. I would like to thank everybody for patiently listening to me. If you have any questions, please feel free to contact me through my email. Thank you.
Thank you, Dr. Vrinda, for a very advanced and insightful presentation. This speaks volume about your double masters in prosthodontics, and it's been really helpful to everyone, I believe. As I already mentioned, any questions, you can either shoot those on the chat box or you can send her an email. Not wasting much of the time, we'll go to the next speaker of today, Dr. Ankur Kaul. Dr. Ankur Kaul, I would invite you for the last and the most insightful session. I'm sure you have a lot more clinical cases to share that can actually reinforce on Dr. Vrinda Gupta's presentation. Over to you, Dr. Ankur Kaul. Please introduce yourself and start the presentation.
Dr. Ankur is muted.
Muted, yeah, I noticed that. And also he need to put it on a presentation mode. As I mentioned, Zoom is a very, yes, but it echoes. Probably Dr. Sridevi Kaul will need to reduce his
No,
volume.
I think she's not here, but anyway.
Oh, now it's fine. Yes.
Fine. I'm sorry, I didn't realize I was muted, but here again, hello everyone. I'm Dr.
Yes.
Ankur Kaul, and I'm here to share my experience of digital dentures with you. A few words about me first. I am currently in the United States and I'm practicing in the greater Boston area. My initial education, BDS as well as MDS, was from Manipal. And after practicing for some time in India, I did move to United States. I'm currently residing in Boston. I'm here to share some of my cases and my experience with digital dentures, and I'll probably add on to Dr. Vrinda's presentation, which was wonderful. She already made it a lot easier for me so that I don't have to speak on a lot of things. Thank you, Dr. Vrinda. So without wasting time, let's start with my presentation. I am here to give my experience with overview of case scenarios when we do digital dentures. I have started doing digital dentures recently for about last 3 to 4 years, and I have noticed that it's a game changer in dentistry. I will cover this under a few topics like introduction, and we're probably going to be briefly talking about conventional versus digital dentures. I'll briefly touch on the digital clinical workflow. We're going to talk about printed versus milled dentures very briefly, and then the scanning considerations, and when we'll move forward. Now, we all know that edentialism has always been there, but now it's become all the more important and pertinent to dentistry because as the life expectancy of people have increased and their means to afford care has increased too, dentures have become very important because people are seeking a better quality of life, and for that purpose, dentures have become important. And this is where digital dentures are making a lot of impact in the life of a lot of older patients and also for the clinicians. And I'm here to speak about that. So if we briefly touch about differences between conventional and digital dentures, we are all aware that conventional dentures have several steps. We have preliminary impressions, we have final impressions. These are the clinical steps. And then we have occlusal registration, try-in, and delivery. And then we have some laboratory steps, which take a lot of effort and manpower to do that. And if we have some mistakes somewhere, it's a lot of effort to correct that and repeat the process. However, when we go to the digital denture workflow, we can reduce the number of steps. And even though errors can happen, the biggest advantage of digital dentures or adopting the digital workflow I have noticed is that the recourse to correction is much easier. If you have a good scan, you can order a new tray. If you have a good scan, you can order a new try-in easily. You don't have to go back and pour the impression all over again and do that. And plus, every time you don't have to call in the patient to make a new impression. So that's a lot of ease for the patient and the clinician and the chairside time that you spend on there. Now, why digital dentures? We're briefly talking about why digital dentures, and one of the important factors in digital dentures is that it doesn't necessarily change the concept of the process of making dentures. What it essentially does is that it helps you to combine a few steps so that the overall process can be smoother and easier and a lot faster. It also helps reduce the cost in terms of time per procedure. And if you're talking about printed dentures, because of the volume done per unit printing, the cost can also come down substantially. There are some studies which have compared the accuracy of the conventional versus digital dentures, and they have said that the digital dentures are pretty accurate, although there are some more studies that need to be done regarding that. So when we talk about digital dentures, the biggest, we can categorize them into three categories. I mean, not only digital dentures, we generally can categorize denture patients into three categories. We have completely dentureless patients where we need to start de novo or start from the scratch. We have some patients who have been wearing dentures for a long time and the dentures are ill-fitting and they need to be replaced, even though they like their dentures. In those cases, we tend to try and duplicate the dentures as closely as possible. And then we have a category of patients which are seeking immediate dentures for themselves. And I'm going to touch on each one of these and talk about the digital workflow for each one of these. First of all, let's talk about the conventional workflow where we have a patient where we want to start from scratch. Now, this patient, Lena, 62-year-old, she already had a denture on the top arch, but she was not happy with it. She did not like the aesthetics. As you can see, that the lip prominence was too much, the show of the teeth was too much, and she was absolutely not happy with it. So we could not use the present denture as a guide. So we had to start from the scratch. So we treated it as a conventional case or edentulous case, wherein we scanned the arches first, the upper and lower arch. The lower arch was supposed to be an immediate denture. And then now what happens after we scan, we just combine the 2 or 3 steps wherein we ask the lab to give us a custom tray with wax rims. When we do the wax rims, we use the wax rims to make the vertical relations, the jaw relations, and we make all the markings in the wax rim. Then we also use the custom tray to do the border molding and make a final wash impression. And then after we have done all this, we scan the upper and lower wax rims and the custom tray, the intaglio and the cameo surface, and also take the bite scans. One thing to note here is that the markings on the wax rims have to be very prominent because scanners have to be able to pick those markings. The markings should not be shallow or should not be light, because scanner has to have some kind of guide where it can reorient the arches. The markings have to be really clear. And once you scan it, you can send it back to the lab and tell them to set up the teeth. Most of the times you don't need a try-in, but there are some cases where you'll need the try-in. So you can ask the try-in. In this particular case, we had to have a try-in because the patient was very, very particular about her aesthetics. So the scan where I said is called a 360-degree scan. You scan the wax rim, you scan the bite, you scan the intaglio of the custom tray with the wax rim and the surface or the impression surface area as well, including the borders. And this is the trial base. Now the trial base, this is called a monolithic trial base. A lot of labs give you the monolithic trial base because of the cost involved, but if cost is not a factor, several labs can give you the regular pink and white trial base as well. And you can trial this, you do the aesthetic try-in, you can mark it on the try-in where you want. If you want any changes, you can communicate same to the lab. You do not have to give the wax try-in to the patient, and the next thing you know, within a week, you have another try-in ready for the patient. And this is the patient with the new dentures. Now this patient opted to go for upper and lower hybrids, and then we had to proceed further with it. So that was another thing we did, like Dr. Vinda already touched upon, the fact that you have to articulate the models to evaluate the space. So you can do that digitally as well. And you can mark how much space you have, and you can actually mark or make a surgical guide based on this digital articulation where you want to reduce the bone, where you don't want to reduce the bone, or where you want to augment, or where you have the bone. And then this patient did go for the eventually for implants placement, and which was done for her. This is the case showing the old prostheses, the new prostheses, where the patient was very happy with the new prostheses. And we finally had placed the implants in the patient, and we scanned these implants. And then she's in trial hybrids right now, and she'll probably be ready for, I mean, it's been over a month now, she's in the trial hybrids. Another advantage here is that now if the patient doesn't like this trial hybrid, all I had to do is to change it according to whatever she wants, or whatever is possible, or whatever is feasible or acceptable. And all she can do is that, hey, you know what, this is a printed trial base, we'll remove it and give her another one. We don't have to give her a wax try-in, because in a lot of cases, like wax try-ins cannot be given back to the patient to try in. So that's another advantage we have with digitization of the process. So, well, this is where the patient was, the old prostheses, the new prostheses, and the trial hybrid prostheses. Hopefully within a month, she'll be in a zirconia prosthesis. Now that was when we start from scratch. Now, in other case, we can always have some patients where they like their existing dentures and they want them to be duplicated. Now, in such cases, again, like I discussed previously, is you can use the existing denture to do the border molding and final impression. Of course, you'll have to check the VDR and VDO and see if you need to make any changes there. And once you establish your VDR and VDO, and then you make the final impression and border molding, you take the bite, you scan the denture 360 degrees, the intaglio surface, the teeth, the impression surface, the borders, and the bite, and you send it to the lab. You can ask for a trial, or you can ask directly to go for finish and deliver the denture. Finally, I would like to talk about the immediate denture cases, which I think is the biggest advantage of digitization here. I will talk about two cases. Now we had one young patient, 31-year-old, like you can see, this is really bombed out teeth, the upper and lower arches. I mean, treating this or rehabilitating this patient was a very difficult situation if we had to go by tooth correction of the situation. I think the best option here was to do a denture in this case, even though you can see the patient is a very young patient. But after looking at the FMX and the so many periapical infections and bombed out teeth, it was decided to go for the upper and lower immediate dentures. However, the patient did not want to go for the lower one because of the cost consideration, so he ended up going only for the upper denture. Again, the biggest advantage here being you know the position of your teeth, you know the position of the arches, you have the bite, you can scan the upper and lower arches, you can scan the bite, and all you have to do is send the patient back home, go back to the lab, correspond with the lab, do the virtual extractions, do the changes however you want to do it, and call the patient. Extractions are done, and soft liner is placed, and denture borders are checked and inserted. So it's a 2-appointment process, which could normally have been a 4 or 5 appointment traditional process where you extract the posterior teeth, let it do the vertical relations, then do the anterior, and then do it in a conventional manner. So this is the patient with the denture in the day of extraction. You can see the before and after. Similar case, we have upper and lower. Again, patient Carly wanted to take out all her upper and lower teeth because the teeth were bombed out. This is the FMX. You do the scans, you have a reproducible bite, you scan the bite, you do the upper and lower scans, and there it is. Dentures with soft liners and on the same day as extractions. 2-appointment process. This is pre-treatment and post-treatment. And when you compare the pre-treatment and post-treatment, there isn't a lot of difference in lip fullness. You can see there's a little redundancy in the lip, but that's because the patient is numb. So one of the aspects of digital dentures that comes into being, or that certainly comes up, so it happened for me, was when you order these digital dentures, the next question is whether you want to do milled or printed dentures. Now, traditionally, what has happened, digitization has been in vogue for a long time, since 1980s, and milling has been the way dentistry has started with digitization in general. So since milling has been there for a long time, it's a lot easy, it's a lot more advanced, and it's a lot more predictable. If we compare, comparing milled and printed prostheses is a presentation in itself. But if we overall compare milled versus printed prostheses, in a nutshell, for all things, milled is slightly better than printed. The biggest advantage of printed is initial aesthetics and cost, because you can print a lot of dentures in volume, so the cost comes down. These are some of the factors which you can go over when you talk about milling versus printing. When you say additive means milling, and additive means printing, and when we talk about subtractive means milling. So mechanically speaking, otherwise, in overall ease of fabrication, it's a lot easier and a lot predictable to have a milled prosthesis. Also, another factor is that it's much more predictable and variability is lesser with milled prosthesis, because it's a pre-polymerized and completely polymerized puck. Whereas when you talk about printing, there's a lot of variability depending upon the machines, the software, and the different systems that are used. So this is an additive method or printing method, and this is a subtractive method or a mill method. And I'm probably gonna see if I can play this video here showing milling. This is the printing. So this was a brief overview of how printing can be done. And now we'll talk about the milling process. And this is the puck from Ivoclar. There are other factors that can be a significant factor or decision making factor when you talk about milling versus printing. But overall, I think milling is better in terms of strength and durability and predictability. But printing is also okay in terms of aesthetics, initial aesthetics, and cost. But again, coming back to scanning, it's very easy to say scanning, but then there's a learning curve with scanning. And the difficulties that I have faced, and I'm just trying to share some of the difficulties I have faced. One of the biggest issues with scanning is that scanner needs a reference point. And when you talk about scanning edentulous arches, it does not have a reference point. And you might sometimes have to create a reference point by probably marking some reference point in edentulous arches so that the scanner can reorient itself whenever you can scan. Then you have to maintain a dry field. Now, sometimes when it's kind of seems like an oxymoron. Your mouth should be dry, but you need the saliva at the same time, which is very difficult. And we all work and struggle with this situation. It's dry. It's very hard to make it a dry field, but at the same time, it's better for the scanning process. Sometimes if the scanner doesn't work, you can always make an impression and scan the impression. The speed and technique of scanning is very important as well. And this is something everybody has to learn and kind of get used to it. There's a learning curve associated with it. And again, there are different systems, scanning systems. You can have iTero, 3 shapes. The dentures that I'm talking about are done with 3 shapes trios. And it's a little different than iTero. They're both the great system, but it's a little different. So you kind of have to change the way you go about it. If you really want to know more about scanning techniques, we have Professor Dr. Lo Russo's techniques. He can also recommend, or he's talked about it. You can go to the website and kind of follow that. And then this is the tentative decision-making guide, which I've kind of made based on my experiences. You can see the workflow depending on what type of denture or what type of case you're treating with. You can have a 2-appointment workflow or a 3-appointment workflow. Most of the times it's either 3. It's 2 to 4 based on how important it is for a person to go for a try-in. And in conclusion, I think the digital dentistry is here to stay. So the earlier we get used to it and get better at it, the more useful. And I think it has significantly helped me make my patients happier and improve my efficiency and my staff's efficiency. I think I really appreciate it, and I'd be more than happy to help anybody transition to digitalization as much as possible. Please feel free to contact me this is my email address, or you can send any questions in the chat box. If I can say anything else, thank you so much for everybody else for giving me this opportunity to present my cases and experience with you all. Thanks a lot.
Thank you so much, Dr. Ankur Kaul. It's a wonderful presentation, and it's very important field that additive and subtractive method, and how we have to make a decision to choose which one over the other. Although we all know about digitalization and digital dentistry, when we come into a clinical approach, what eases the situation, what makes it more convenient is very important to know. When you speak about the difficulties you face, it's really important and easy for other clinicians who practice this to get some motivation and also get some rough idea how to go ahead with it. Thank you so much. Maybe you can stop sharing the screen now.
Oh.
Yes. It's been all 3 wonderful speakers here, with the geriatric dentistry being one of the upcoming field. And this making these appointments easy, coming up with most of the advanced technology and giving some consideration to their medical condition. Everything plays a very important role here. And the main motto of our organization is the same. And we are very happy to have this collaboration and have the CDE. I see that Dr. Shambhat sir, Dean of Yanapaya Dental College, has joined this meeting. Thank you so much for joining, sir. We really acknowledge your presence here today. I saw his name, and if there's anyone who has joined from any of the institution, we would like to see them on the chat board so that we can acknowledge, because we truly appreciate your participation and your cooperation. So we don't do any of the formal introduction or formal like how we do in normal CDs, because with the FSCD and geriatric board, we mainly follow the goal of kind of like giving more priority to the presentations. And we have our chairperson today, Dr. Sridevi Kaur. I would like to ask her inputs for all the presentations. And Dr. Sridevi Kaur, over to you.
Thank
Your
you.
valuable comments is appreciated here.
Thank you. Thank you, Dr. Vinya. What a scintillating 1 hour. So they're basically telling us you can like mill or print a denture in like 20 minutes. So without the endless hours of toil. I do
Yes.
same day crowns in my clinic. And it's like a blessing. And I'm looking forward to work with dentures too. And Dr. Yuvika basically, in her calming voice, she told us how to go about the extractions, how she gave us like a brief overview of the most important things, like automatically you should just think about the ASA classification, and you should like kind of classify the patient and start off with the medical clearance. And she also touched upon the black box warning on clindamycin, which reminded me one of our professors in dental school used to tell, we teach you like so many things, but 50% of it is true. And then when you start practicing, you will know, you will kind of figure out which 50% it is. So it's like clindamycin was always the go-to drug in allergies to penicillin. And now we are switching to azithromycin instead of clindamycin. So that's been my experience. So we kind of just, she kind of reiterated the importance of lifelong learning by saying that I feel like you should stay in touch with what is current in medicine as well. And of course, she shared with us the latest regimens. Thank you, Dr. Yuvika, for that wonderful presentation. And then, of course, Dr. Vrinda, who's the most current with her knowledge in the most current techniques. I was like trying to keep up like with the slides, honestly. Like, I think it needs a masterclass. Like, it was a great presentation, Dr. Vrinda. It was really like from the very basic, like the analysis till the technique work. It was really a great presentation. And
I know personally, and whatever she shares, like, that is the dedication she shows even clinically. So it's a very rare combination having, the sound practical and the theoretical knowledge.
Yeah, like
Yes,
it's
very
like
appreciated.
bringing the art and science together, truly,
Yes,
right?
yes.
I mean, that was
Thank you so
awesome.
much.
That was really good. And then, of course, Dr. Ankur's cases were like giving a denture in 2 visits. And you can see like how thrilled the patients would be, like what the rampant caries, the youngster who came with the rampant caries, and like what a life-changing, like what confidence it builds, like just to give that denture in 2 appointments. It's amazing. I think they did a fantastic job, all the 3 speakers. And I won't take much of the time, and let's go ahead with the certificate presentations, and then your concluding remarks, Dr. Vinya. Thank you. Thank you for the opportunity.
Thank you, Dr. Sridevi. So as you're here on screen, I would request you to present the certificates of appreciation to all the speakers. So Dr. Esther Nalini, maybe we can take her help. Yeah, she can share the screen and you can
Thank you,
hand
Dr.
over the
Esther.
certificates. Yes. On chat board, I see Dr. Vidya Bhatt, Professor, Yanapoya Dental College, Mangalore. She's here as well. We acknowledge your presence, ma'am. Thank you so much for joining. Manu ma'am is extending her compliments to all the speakers. Thank you, Manu ma'am.
Dr. Esther is muted, Dr. Vinya.
Dr. Satarka. Oh, yes, probably. Maybe. I think she's going to share it on the screen.
Okay.
Dr. Esther, will you be sharing the certificate on the screen?
I think I can see the screen.
Yes. But not like...
I think it's not the full screen yet.
Yes, she is texting probably. So Dr. Yuvika, thank you so much for the very wonderful presentation. It's so important to be mindful about all the medical conditions and how responsible we need to be when we are prescribing antibiotics, how when it is always a second line of choice when patients are allergic to amoxicillin, we blindly sometimes choose clindamycin, although we have also azithromycin as a choice. So you mindfully explained us how deteriorated it can be with the older adults. I would request Dr. Sridevi Kaul to hand over the certificate to Dr. Yuvika Rajkumar.
Yuvika.
Maybe you
Yuvika,
just have to like click on that probably.
click on, oh yeah, right here, yes. Double click maybe.
Thank
should
you
I-
all for your compliments
Thank
and
you.
wishes for all the presenters.
You cannot see it on the screen, right? I
Yes.
don't.
I think it should be okay. It can be some technical error, but maybe we can email all the certificates to our presenters. Thank you so much for the
Yes,
wonderful
that should be good. That should be good.
Yeah.
Yes, we can
Okay.
email all the, yes, that will be more convenient. That should be okay,
I
Dr.
put there, but there is something them up.
Yes, yes. So that should be fine.
We
So
can
now,
conclude the program. That's not an issue.
yes. Like now, as we conclude this enlightening session on caring for aging smiles, whatever best practice and approaches we have got from the eminent speakers, I would like to extend my heartfelt gratitude to everyone who contributed for today's event. First and foremost, I would like to express my sincere thanks for Board of Geriatric Dentistry, Federation of Special Care Dentistry, and the KSR Institute of Dental Science and Research and Good for their invaluable collaboration in organizing this event. Your joint effort have played a very vital role in sharing this knowledge session and advancing the standard of geriatric dental care. Thank you so much. Our deepest appreciation goes to the esteemed speakers of today, Dr. Vrinda Gupta, Dr. Ankur Kaul, and Dr. Yuvika Rajkumar for their thoughtful, provoking presentation with their expertise both from India and from the US, how their enriched knowledge and outstanding approach has undoubtedly influenced most of the postgraduate students and interns who are sitting here today, and also the upcoming practitioners. And we have many clinicians and many other organizations who have joined on board. So this is going to be a really impactful and meaningful effect for their day-to-day practice. A special thanks to our chairperson, Dr. Sridevi Kaul, for her excellent leadership and guidance throughout. You know, like there were a lot of commitment that was involved throughout this process. Even now, we all are sitting at midnight, but it was a real fun-based last 1 week, and it's been a good teamwork. It wouldn't have been possible without our very proactive CD convener, Dr. Smita Attavale ma'am. Her tireless efforts in, with all the CDs we host, it's been like extremely good, and she elevates our standards actually. So I'm really thankful to her. Your commitment really ensures her to provide us, more and more. I would like to acknowledge Dr. Manu ma'am, our dynamic chairperson. As I told, her leadership, mainly her visionary leadership and her support, has been immensely very helpful throughout for us to organize CDs since last 2 years. Dr. Priya Verma, our Honorable General Secretary General, has been a very dedicated support to us. Her contributions has been instrumental in throughout all the growth that we have in this board. I would like to extend sincere gratitude. Very important person of today, Dr. Esther Nalini. She don't like to be on limelight, but I really want to put the spotlight on her today for her dedication and immense support that she has provided from the beginning. And it's just not the first CD we are having with her support. It's been like I had one last year. It has always been like walking on cake. Thank you, Dr. Esther. You make it so easy for us. I most of the time don't even feel that we are coordinating from this far. You make it like we sleep and morning things are ready. And we tell her something in the morning, by the time we are done, like, we have everything in place. So thank you so much for your deep value and ongoing contribution to the board, as well as for the CD program that we have been having. A special acknowledgement to your chairman, and who has been Mr. Srinivas Rangaswamy. He's been a really good support, I'm sure. Without your kind support from your principal and from the chairman, I'm sure you would also require the driving force, and they have been very commendable and being very supportive throughout for us. Thank you so much. Finally, and not least, definitely all the participants, the postgraduate students and the attendees, participants who are like practicing clinicians, our board members. I see most of them from our geriatric board here. Thank you so much for dedicating this time for today's session. Once again, I would like to involve all of them. I only saw greetings from Yanapoy Dental College. I would like to extend thank you to Dean Dr. Shambat sir and Professor Dr. Vidya Bhatt for joining for today's session. And I am not sure if I've missed any other professors from any of the other dental college, but I'm very glad that nationally most of the colleges have joined together and participated today. It's all we need, journey of learning and improvement in growing together. Thank you so much for making this a very meaningful session today. Okay, now I can say you all have a good day ahead, but we need to have a good night.
You please have a good night's sleep now. You have done a wonderful job. Good night.
Thank you all.
Thank you.
Conclude
Sure.
just I
Yes.
greeted the Board of Geriatric Dentistry, and I strongly endorsed what Dr. Vinaya said, and without repeating that. And I place on record the wonderful work done by the Dr. Vinaya. Lots of compliments to you. Thank you so very much, Dr.
Thank you
Vinaya.
so much, ma'am.
Congratulations, Dr. Vinaya.
Thank you. Thank you, Dr. Shambat, sir.
nice,
Thank
so
you so much for joining. Very delighted to see you here, sir.
Thank you. Bye-bye.
Bye.
Have a good night, Ashton.
Yes, we do indeed need sleep
Good
now,
night.
all of us. Thank you.
Thank you.
Thank you, everyone. And we wait for your feedback. Please send your feedback to Dr. Esther Nalini, and we will take cues from there. If we have to improve something, if you need to learn something else, FSCD, Board of Geriatric Dentistry, is always there for you. Thank you so much. Thank you, Vinaya. Bye-bye.
Thank
Bye,
you.
everyone.
Bye. Bye, everyone.